Hello, welcome to the third session of the Forum Europe AI conference. Today we're going to look at healthcare in AI. I'm Simon Greaves, I'm the Executive Director at Harwood Levitt Consulting. We're a Brussels-based public affairs and strategy firm who specialize in healthcare, pharmaceuticals and tech. So today we're here to talk about the application of AI in healthcare. This was going to be a fascinating third session for today after a number of really interesting sessions that we've heard so far. I think we're going to hear what makes healthcare and AI so unique, namely, the potential, the opportunities from improving diagnostics, thinking about radiology and imaging, to monitoring patients through wearables and the apps that many of us have on our phones right now, as well as automating some of those clinical tasks, thinking of chatbots and the others. So a huge world of opportunity there, but clearly some real significant challenges as well, which we'll seek to discuss and address today. One, around safety of these products. Second, liability, linked issues of privacy and data sharing, trust underlying all of that. And then I think we'll probably get into issues around bias as well and some of those equality questions. So we've got a really distinguished set of speakers today. And we're going to get underneath that issue through an initial opening presentation and then a panel discussion where I'm sure many questions will come from you in the audience as well. First, I think I'll just introduce all of the different panelists before we go to that opening presentation. First, we can see on the screen, excellent. So first you can see up on the top right, Laure Wijnants. Laure is a leading academic in the field of healthcare AI, a background of biostatistics and sociology, currently assistant professor at the University of Maastricht, and also a postdoctoral fellow at the Research Foundation Flanders. And we'll hear about your presentation in just one second. We've also got Lubna Burfa. You're a machine learning scientist turned entrepreneur and the founder of Okra.ai, an AI data analytics company for healthcare. And you've been a member of the EU high-level group as well. And so I'm sure we'll have some interesting insights from that side. Michael Strubben from MedTech Europe. You lead the digital work at MedTech Europe, the association for the MedTech sector in Europe. You're also an expert in policy at the intersection of health and technology, because you've worked previously at the Personal Connected Health Alliance, among others. So welcome, Michael. Janos Tolias, you're a leading global expert in AI medicine and law, currently at the Commission in DG Sante as legal head on AI and liability. But you were previously, I see, in New York Law School and worked in other universities on EU law and constitutional law. And finally, Roberto Zigari, internationally recognized expert in the field of big data and databases, founder of the Frankfurt Big Data Lab, and a visiting professor at Berkeley as well, when you can leave the country, that is. And we'll hear more from you later about a very practical application of how one assesses trustworthiness in AI. So looking forward to that. So hopefully that's helpful just to give a picture of our very impressive panel of speakers. We're going to start first with a presentation from Laure. Laure, you're going to cover how different AI models have supported clinical decision-making in COVID, so very topical. And I think it will reveal some of the inherent challenges and where progress is needed, which will be a good conversation starter for the panel. So without over ado, over to you, Laure.
Thank you. Thank you for the introduction. So from the very start of the pandemic, we've seen a lot of interest in AI and how it could help battle COVID-19. For example, in the UK, you have the Q-COVID models, and based on these algorithms, 1.7 million vulnerable people have been added to the shielding list, and have also been prioritized for vaccination. While in the United States, you have several clinical decision support algorithms for use in intensive care that have been FDA approved. So for good understanding, when I say models, I mean diagnostic or prognostic models, which means that they are data-driven algorithms that are meant to support clinical decision-making for individual patients. And they do that by combining and giving appropriate weights to several input variables, for example, CT image characteristics, signs and symptoms, lab test results, demographics, etc. So in the clinic, these can take on various forms. They can be translated into a simple decision tree like this, or into a simple risk score, or into an online application, a mortality risk calculator, like here, or built into software that automatically interprets a CT scan. So why is that? Why was there this interest so very early on? Well, we know from previous research for other diseases that a good model can improve care and can simultaneously reduce your healthcare costs. And it's very useful to help allocate scarce resources because you can do a risk-based or very tailored, personalized approach, targeting care to those who need it most or those who would benefit most. But there's another side to the coin. We also know that poor models can make matters worse. So we know from decision analytic theory that actually a bad model can have a lower net benefit than either classifying all patients as positive or classifying all patients as negative if you take all downstream effects of a false classification into account. And we also know from the swine flu pandemic that models that usually work very well don't necessarily work well in a pandemic situation. So from the very beginning of the COVID-19 epidemic, we've set out to review all prediction models, all diagnostic and prognostic models for COVID-19. So we started this effort in March. In early April, the first version of the review was published in the BMJ. And since then, we've had several updates and it's still ongoing. So this is really a living systematic review. So how did we do that? Just to give you a few ideas of how we worked. We have this essential toolbox. So we have the CHARMS checklist, which is a standardized checklist of key facts and figures that you need to collect from each model to enable a quality appraisal. And then there's a robust risk of bias tool. So numbers are only as good as a process producing them. So the PROBUS tool asks 20 signaling questions on 4 domains. For example, regarding the participants whose data was used to build the algorithms, questions on how the predictors were measured that serve as input to the algorithm, questions regarding the definition of the outcome, the thing that you're trying to predict, and questions regarding the analysis. So how was the model built and how was it tested, or we say, how was it validated? So which methods did we use? Well, we did a systematic search of the literature. We searched peer-reviewed articles, but in the beginning of the pandemic, we also include preprints because the sense of urgency that we had at the time and the fact that the traditional academic publishing couldn't keep up with the pace of research coming out, we decided to in the earlier versions of the review, also include the preprints. So what's the scope of our search? We include 3 types of models. So first, the models that identify high-risk individuals in the general population, so people that are currently healthy. Then the diagnostic models, so the models that, if one is symptomatic or had a high-risk contact, determine the risk of the presence of COVID-19 or the severity of COVID-19. And then we have the prognostic models, so the models once a disease is confirmed or highly suspected that predict whether, for example, somebody will die of COVID-19. So we had 43 reviewers working on this. Each model was reviewed by at least 2 independent reviewers, and each of those independently answered 127 questions about the model. In case there were more than one model proposed in one study, we extracted data and then a quality appraisal of each of those separately. So what you, of course, are all interested in here is the results. So what did we find? Well, we assessed, so far, we looked at approximately 40,000 studies on COVID-19. And among those, we identified 169 studies that had a diagnostic or prognostic model for COVID-19. Those were included in the review, and together they proposed 232 models, 7 for the general population, 118 diagnostic models, and 107 prognostic models. Where did the data come from? Most of the studies used single country data. Often that country was China, but by now we've seen models developed on data from all over Europe as well. Most of the models were intended to be used in hospitalized patients, so patients with either confirmed COVID-19 or suspected COVID-19. And what's very interesting is that 42% of the models that we've seen were available for use in clinical practice. For example, through an online, freely available web calculator anyone could go to. What are the characteristics of the studies? Well, we distinguish between the model development and external validation. So external validation is the toughest test of your model. It means that you're testing your model in really independent data. For example, data from another hospital, data from another country, and you see that it is rare that this external validation was done. In terms of methods, about 1/3 of the algorithms that we've seen use logistic regression, another third use neural networks or deep learning, and then the remaining third, that was really an array of different types of methods. In terms of predictors, the inputs, you have your age, comorbidities, vital signs, image features, sex, signs and symptoms, contact with COVID-19 confirmed cases, and biomarker values. And then, of course, what you all really want to know is how well are these models performing. I present you to the C statistics. So to give you an idea, if you would flip a coin, you would get a C statistic of 0.5, so no better than random. If you would be perfectly able to distinguish who has COVID-19 and who doesn't for the diagnostic models, or who will die and who will survive for the prognostic models, you would get a C statistic of 1. And just by looking at this slide, you would get very enthusiastic, because you see in each category we have models with C statistics very close to 1, very close to perfect. So you think, okay, immediately we have to put this in practice, because we know in advance, we can predict who will die and who will live. Well, that may be a bit too optimistic, because the other result of our review was that the risk of bias in the studies was very high. So risk of bias, that's defined as systematic flaws in the design of the study or the analysis of the data that make it very likely, or that introduce systematic error in the predictive performance, the estimated predictive performance. And you see that actually in all categories, the overall risk of bias was high for all models. So we haven't been able, in the first original review and the next 3 updates, to identify a single low risk of bias model. And you may think that we were too pessimistic, but later on, by external validations, our fears of optimism have been confirmed. And we consistently see large drops in the C statistic. We even see that in terms of clinical utility and net benefit, these models don't perform better than oxygen saturation on room air alone, or better than age alone. And several studies have indicated that the findings weren't replicable, or that the output of the models didn't correspond to expert assessments of the same patients. In terms of impact of our study, the World Health Organization has used our analysis for their clinical practice guidelines or the patient management guidelines, and currently they don't recommend any of the decision support system for prognosis. Our model has been, our paper has been widely read and cited, and that has had a nice consequence that people picked up on the issues that we identified and tried to improve them. And by now, luckily, we have our first low risk of bias model. We've assessed this for the next update, so it will be included in our next update. So the Q-COVID models that have been used in the UK, we rated them as low risk of bias. And in the meantime, they have been validated in 80% of English adults, and they work wonderfully. So what do these models do? They predict for people who are right now healthy, so in the general population, the risk of catching COVID-19 and subsequently dying with COVID-19 or being hospitalized with COVID-19. So what are the review's limitations? Of course, there are limitations. There are always limitations. For us, a big one is that there are other models available, for example, in-house developed models or proprietary algorithms that are out there, are available, but they don't have scientific reports accompanying it, and we couldn't review those. So we have some indications that their quality is not necessarily better than what we've seen here. And a pretty tragic example is the Surgisphere models. So they have models publicly available on their website, and those models had been recommended for use and have been put in use in real patients in Africa, in several African countries. Later on, it was highly suspected that Surgisphere fabricated their data and the models had to be retracted. But of course, the harm had been done. So in conclusion, it's a bit of a strong statement, but I think despite reports of impressive predictive performance that we've seen, much of this growing body of literature on prediction is essentially worthless. You should never trust a good reported performance alone. The study design, the analysis, and the validation really matters. So how can we do better next time? How could modeling help during a pandemic? I think to get quick models fast, to get usable models fast, first you need representative data. These models, data-driven models, they require a lot of good data. And there's data available, it's open, but it's not necessarily representative of the patient populations that people really see, that clinicians really see in their practice today. Then I think we need multidisciplinary teams. So we've seen a lot of highly technical models that don't match the clinical needs. The reverse happens also. We've seen a lot of models that seem really attractive to clinicians, but are a bit amateuristic. Then I think the last one is that it's necessary to share models. Really making your models available for other people to test them and to make head-to-head comparisons between models is the only way to quickly identify which models work and which don't work and which work best. So this was a large undertaking. So I had a large team doing this with me. These are all the people I worked with. And these are my acknowledgements. If you would like to go over these results on your own tempo, we have a website on which we have a layman's summary of the results and the study. We also have links to the data that we extracted and to the publications where we describe our results. And of course, you can always contact me for any further questions. Thank you for your attention.
Thank you so much, Laura. That's a pretty fascinating sort of bit of research that you presented there. And I think, a few things which I've noted down, but just a few catchphrases, and I've got a question. A good model can help improve care and reduce costs. Models in general didn't work well with COVID and in general other pandemics. And there's that risk of bias or systematic errors in predictive models. And I think the catchphrase, numbers only as good as the process producing them, struck home. You also seem quite optimistic, though, in your final slides and in the prescriptive path forward. But just a question, I guess, is, what accounts in your view for that risk of bias?
We've seen a lot of, well, the biggest issues that we've seen early on in the pandemic, it was availability of data. So we've seen models presented as COVID-19 risk prediction models that were developed, one example, completely with pre-pandemic data. So no single COVID-19 patients in there, but the model was advertised as a COVID-19 patient database model. So there were problems in the beginning, availability of data, but then a huge problem was the statistical analysis, or the model building. The analysis was done to build and test the model. So what we've seen is that people are using very highly data-intensive modeling procedures on small amounts of data sets. So a result of that is overfitting. That means your model works really well in the data that you've trained it on, but it doesn't generalize to other patients. And that accounts for the over-optimism.
Super helpful clarification. And a final one, and we'll come back, I'm sure, with other panelists will have questions in the Q&A and other people in the audience. But just any sort of where, again, a layman's question, but where's the best, for that best possible model, where have you seen it practically applied? Is there any examples of success that you can point to in real world use?
Specifically for COVID-19 or in general?
Ideally COVID-19, but if not, in general.
Yeah, so I think, yeah, the Q risk models, that's the example of a good quality model. So I mean the Q COVID models, that's the example of good data collection, good quality modeling, and then policy acting on that modeling. And I think that is the ideal situation.
Okay.
So in that case, people were added to the shielding list. So according to the algorithm's output, so they were run on the general UK population. Nobody was taken off the shielding list, but people who were based on multifactorial, for multifactorial reasons. So for example, age combined with comorbidities and background characteristics, they exceeded a risk threshold, and they wouldn't have been on the shielding list otherwise, but they were added based on that multivariable approach, added to the shielding list. And I think that's a good way.
Excellent. So in the UK's response to COVID, the shielding list, people that should be staying at home. Yeah, I'm based in the UK, and that's a very present, it's a very, it seems like a success when it's talked about in the media. Okay, well, look, Laure, thank you so much for helping to sort of frame the discussion. And we'll come back to you later, I think, after we've heard from the other panelists and hear more. And I'm sure panelists will also have some questions or comments on what they've seen. Excellent. Okay, well, thanks again to Laure. So next, as described before, we're going to go through a series of different questions with our distinguished panel. And we really want to sort of emphasize there's a few areas of focus, I think, for this session, the panel discussion here. The actual situation now, so how AI is being used right now in Europe within the healthcare sector. We want to look at the future. So what's the potential? What's the opportunity? If Europe is really visionary about AI, and what does that mean in healthcare? And where can we sort of move forward, maybe ahead of global competition? And third, thinking about stakeholders. This impacts on stakeholder relations and on the interrelations of different professions, the medical profession and society as a whole. So, you know, what's the benefit, where the benefit's going to be drawn, and where maybe the challenges, thinking of different groups. And finally, we started with this in a sense, but the impact of COVID. How far is COVID going to catalyze or challenge the rollout of AI in healthcare? So they're the four kind of key questions which are front of mind for me. So first, we're going to turn to Lubna. So Lubna previously introduced you as a machine learning expert turned entrepreneur. You're based in Cambridge, I think, today, Cambridge, UK. And you're going to talk a little bit about your vision and I think the opportunity for AI in healthcare and how it can really help drive and defeat disease in the future and prevent disease in the future. So over to you, Lubna. Look forward to your remarks.
Thank you, Simon. So before we look at the opportunity AI can offer in the future, just let's for a moment perceive the process of bringing, new treatments from the science lab to the patient today. So traditionally, we know and accept that this process takes years, and it has to, in order to ensure the safety of those treatments. But if you look from the other side, and we've been in this situation with the COVID pandemic, many patients across the world are waiting to get access to novel treatments that already exist. And it is an injustice when it turns out that those treatments exist somewhere else, and you cannot get them as a patient, either because it's maybe not approved in your country, or because it is approved, but your own doctor is not aware that this is the best medication for you. So at Ochra, we are using AI to facilitate bringing those treatments much faster to patients. What will be new and different in healthcare through the use of AI in ways the patient of today cannot imagine. And we see this traditional approach of doing science as a thing of the past, part of science history, fit for the previous century and not for this one. So what has changed exactly that makes a situation like this unacceptable? So, well, we know about AI. It gives us the tools to be able at scale to bring those drugs faster. It's this formidable technology that can take science and innovative treatments to the next level and bring it to the right patients. But also the COVID, of course, and my co-panelists will elaborate on that more, showed how we can speed up a process that takes, an average 10 years of clinical trials to 10 months. And so the going back to what it was is not possible. And applying AI principles on some of the empirical data will soon look like the infancy of science. And we, for example, at Ochra, we are looking to help healthcare benefits from this new stage of developments to bring those innovative treatments faster. So let me explain you how. So the best trained human can only go through so much data and come up with conclusions. And with AI, it's like hiring this fastest calculator that can go through all the available data, all the data we have in history, process it, and combine it in a way that a human cannot anticipate. And all of this achieved in tremendous speed that can mean that we no longer have to wait for 12 years while our loved ones suffer. At the time needed to get from the scientist's aha moment in the lab to offer this medication to the patients may be cut in in an amazing way to a fraction of the time. And so looking at our planet, we have 7 billion of us. And scale is important. As much as my previous panelists speak about those nice methodologies, maybe proven in one country or in one lab, scale for AI is important. We need to be able to serve this big population. And we see the process happening right now with the COVID vaccines. So more than 7 billion of us, and we are all unique, and it is in our DNA to be unique, but those algorithms can help compute the similarities between us and bring in the right treatments for us. And although AI is inspired by the way we learn humans and is used the way we learn, it doesn't need to pass the Turing test to be relevant. So the equivalent for the Turing test in engineering is to create an airplane that flies like a bird. And we didn't do that. We created an airplane that used aerodynamics laws to enable to fly, which means in healthcare, we don't need to build AI that replaces any individual, a doctor or a nurse. We are building AI to augment decision-making. So when I think of this, I always come to the questions, can we keep affording to miss the opportunity to treat so many patients just because we are set in our traditional way of understanding science and performing healthcare? So looking to the future, how can we use this technology even beyond bringing this drug faster is to prevent diseases. So AI could be this scalable technology on the back end for big markets like Europe, and that be processing data in real time from every one of us, every time we visit a lab, every time we visit a doctor, to help build a proactive healthcare system that don't wait for people to get sick in the first place, to have computers analyzing health data, measuring similarities between patients, conditions, computing probabilities, scoring risk of patients, triaging patients for major and minor conditions. And once there is a risk flagged For example, kind of traffic light system. Once we're, a red light, we receive a message to get a screening or a test done in a lab close to our living or work area. And once the results of tests are available, other AI algorithms will be analyzing and triaging our case to either a routine case, a specialist case, or an urgent case. So far, there is no human picture. So far, it's only automation. So once we're aligned or we have a kind of triage happens, we can go and see the right expert for our case. So once we see the experts, more tests, for example, can be made, and AI algorithms could leverage all the patient's data of patients in similar conditions to us, that's seen so far, to provide the right treatments underpinned with the evidence and the reasons why. And this is not just an AI algorithm that makes the decision. All the possible options will be presented to an expert doctor that will make the decision finally what needs to happen. In this way, this is much better than having just a 15-minute conversation with a specialist we never met in the past. They are not aware of all our historical data. This is underpinned with all the evidence from our past, as well as patients similar to us. So, which means even for patients with a very, very unique conditions, such as rare disease, and their doctor may maybe never seen a patient like them in the past, with this technology, they will have all the evidence in their hand to be able to make, the right decisions. So for the patients and the caregivers, awareness means everything. And living with uncertainty every day is daunting. How to reduce this uncertainty until it is clear what treatment, needs to be provided, but also bringing the speed to get to that treatment. That is what this technology can bring, but it only can bring this if we create the scale, and scale comes with the data. So I'm happy that one of my co-speakers is going to talk about the European health data space, because we need European data. At the moment, we're training our algorithms mostly on US data because it's more granular to be able to make decisions. So we need to have a scalable data infrastructure where we can train those algorithms and make our healthcare system scalable, proactive, and allow us to treat the scale of the populations with the best treatment possible. Thank you.
Thank you so much, Lubna. That was, again, a really sort of good view into the future. I think building on what we heard from Laure about the challenges around Q-COVID, there's definitely a sort of optimistic picture there that you've painted about where we can get to. I love your sort of comment about how there's really a focus on augmentation of decision-making. We're not going to replace birds. That's not the ambition. So I think that's a nice illustration. And the sense that with AI as a scalable process at the back end of health systems, we can really become a prevention service or move towards that. So really, really sort of good thoughts there. Just, you mentioned there, we're talking about EU level action here, of course, and you were on the high level group. And so I was just struck when you talked about how for rare disease, there were maybe particular opportunities to work between very national health systems. So are there any other, do you think that rare disease would benefit to a greater extent than maybe other disease areas? Any thoughts on sort of where the greatest benefit will be gained first?
I think in every disease, there will be gains. For rare disease in particular, the volume is very scarce. We don't have much examples to learn from. And for example, I met a caregiver of a patient that have a rare disease in Switzerland that they didn't have any cases in Switzerland. And she took her 15 years to get the diagnosis for her daughter. While in other countries, there were more examples. So having that multi-country approach, that we have that data in one place, we train algorithms with all those, it will be very, very fast to diagnose the case of that daughter. Then we train algorithms only with data from Switzerland because there is no examples in Switzerland. So that is for rare disease specific, but also for diseases like lung cancer, where we suffer in Europe, having that volume to be able to diagnose fast patients to have, and we know with cancer, early detection is very important. If we can use all the data to be able to predict for who needs to be screened and at what time to avoid, the mortality, then we can also AI algorithms fast. So in this scenario, it's a win-win. I mean, the only lose situation is when there is a privacy issues of data, which we already know we can prevent. We are using anonymized and identifiable data sets to train AI algorithms. We don't need to have data on the patient level. So if we have the right infrastructure and the right way we anonymize data, then it is we should move quickly to the scale and not only look for small studies. We validate the technology, then we have to move quickly to scale and not stay stuck in the validation phase.
Move to practical implementation. Excellent. Okay, thank you so much, Lubna. Really good additional insights, and we'll come back as a panel very shortly. So thanks for that. We're obviously, the use of medical technology and the impact of AI in that sector is very significant. And I know MedTech Europe, the association, has done some interesting work in this space. So we're now going to hear on the impact of AI in Europe. So building on, we've heard about the vision and the opportunity there. We also, let's see a little bit of some facts and some statistics about the healthcare sector at the moment, the healthcare AI sector in Europe at the moment. And Michael Strubin from MedTech Europe, if you're there, you're going to sort of share a few insights from your organization's thinking. You're on mute, Michael.
I have not unmuted myself. Am I now? I have not touched my dials. Are you? Wait a second. Let me see whether I can unmute.
No, you're fine now. We can hear you fine.
Okay, somebody else, a kind soul, has unmuted me. Very good. So thank you very much for the introduction, and thank you very much for the invitation to join this panel. Loved the presentation from Laure and from Lubna, and I think we very much at MedTech Europe agree that AI has enormous potentials for the delivery of the delivery of healthcare. I brought a few slides here, and I hope you're forgiving me for. And here they are. That's wonderful. Because I indeed, as you alluded, Simon, I wanted to report to you from a recent project that we did in order to indeed quantify the impact of AI in healthcare. Next slide, please. Quickly, and I'm not doing this just because I'm asked by my comms people to always tell you who we are, but I wanted to just highlight here that the medtech sector is just a very important part of the healthcare industry, and we, of course, we are the industry association for the medical device and in vitro diagnostic device sector. We're particularly interested in ways in how our technologies can foster and improve the actual delivery of healthcare. So we're a little bit different from, say, for example, the pharmaceutical sector that uses data to crunch it and then come up with new medicines, something that Lubna has talked about and which we very much support. We are looking very much at how we can make AI useful for the actual delivery of care. Next slide, please. And to that extent, we thought last year it would be a good idea that we start not only talking about anecdotes and talking about vignettes, but that we actually commission some research that looks at how AI can deliver a socioeconomic impact on European healthcare systems. So we wanted to quantify the impact of AI, identify barriers, and articulate some policy recommendations, something that my previous speakers have already started doing. So we teamed up with Deloitte, and I think we came up with some really good results. Next slide, please. So we looked at where AI can make a difference, and we worked with the Deloitte team, and particularly the health economics and health economics analysis team, to come up to kind of segment the world of AI in healthcare and medical technology. And they proposed the way they wanted to cut and slice and dice the field, and proposed that we look at, of course, wearables, imaging, labs, monitoring, real-world data, virtual health assistants, personalized apps, and robotics. And we asked them to quantify the impact in terms of how many lives could we save, how many hours of work could we save, and how much money we could actually save in terms of of efficiency gains by using AI. And very much on top of this came the whole area of wearables. So wearables can make a difference. For example, when we assist people with diabetes in their self-management, when we equip people, old people or others, frail people with monitors that monitor their movements and detect faults if that is an issue. When we equip them with wearables that flag early on risks of deteriorations, for example, heart conditions. One other big piece is, of course, imaging. Radiology, AI in radiology has probably made the biggest advances, and we've made enormous, powerful impacts on detection of cancers and other anomalies in medical imaging. If you want to go to the next slide here, and our report details all of these in great detail, and we invite you to take a look at it. So our headline results were that if we can really get this right, we can save 400,000 lives annually in Europe. These are all European numbers. That's the equivalent of 2/3 of Luxembourg, or a medium-sized city. We can also save 200 billion euros in savings. That's 12% of the total European healthcare expenditure. And we can free up 1.8 billion hours. And we calculated that this would be the equivalent of about having 500,000 additional full-time healthcare professionals in Europe. Next slide, please. Now, in order to get to this holy grail, we really need to address some of the critical issues that we summed up as follows. So that there are, of course, the data challenges. Lubna and Laure have already hinted on those, and we can probably talk about it a little bit more in the discussion. We don't have data yet. We don't have data in the sufficient quality yet, and where we have them in the quality, we can't necessarily access them due to data privacy restrictions. We also need to address some regulatory challenges, and I think my colleague Janusz from the Commission is going to talk about it. And of course, next month, when the Commission comes up with its legislative proposal, we will learn a whole lot more about how the Commission proposes to regulate us. We also need to look at organizational challenges. Just one thing, nobody, as this is a truism that you all probably are familiar with, nobody's ever paid for preventing a disease. That's something that we need to address, and we need to probably change, because we want to become healthier. We don't just want to address sickness better or faster. We want to keep people healthy. And finally, there are some critical issues around trust, around skills not only of healthcare professionals to deal with healthcare with AI, but also the average person. I cited earlier the person with diabetes, to use the kind of tools that will be at their disposal. Next and final slide, please. So our policy recommendations detail our recommendations of how to address this. Obviously, we need to really improve the database for AI. We need the right policy frameworks for that, and then the appropriate regulatory environment. We need the right infrastructure, the data policies, to improve the evidence on which we can develop and train AI algorithms. And of course, a number of additional items, something that the industry never tires to say. We also need to figure out how we pay for AI and provide the appropriate reimbursement mechanisms for that. Interoperability and others are critical issues that we need to address. With that, last slide, I'd like to invite you to take a look at the report, download it, and if you have any questions, please get in touch. I hope this was useful.
Thank you. Thank you so much, Michael. That was a really good overview, I think, and providing us with some numbers, with some kind of evidence for both the current sort of scale, but also, I think, the opportunity from efficiency savings. But then I think also 12% of health system spending is a big number. So efficiency savings. And then I think also just really nicely laid out some of the policy questions that we face and that will hopefully be addressed next month and beyond. Just one quick follow-up question. Obviously, you're representing the sector and it's medtech, but you've also taken a broader view here. Any thoughts on sort of the European opportunity? Because European startups and many other companies, including obviously Lubna, who we heard from. Any comments on that, on the opportunity for Europe?
I think we have a real opportunity because we're building the right social framework for data and trust in data. Many people have observed that China or the United States have different ways of building the database and sometimes have a cavalier attitude towards data privacy, data protection. I think we have an opportunity with the GDPR and other guardrails to build the type of AI that is human-centered. And I think Lubna, who's been part of the AI high-level expert group, can probably echo some of these. But we also need to make sure that we strike the appropriate balance here between data protection, but also making data available. And I think that those are the types of conversations that I really look forward to having with policymakers, with stakeholders, and anybody who's really interested in making AI a reality.
Very helpful way of ending. Brilliant. Okay, thank you so much, Michael. We'll come back in the panel exactly to address some of those questions. But I think you really nicely set up some questions about what may be some of the challenges, and I think also what may be coming from the European Commission soon. So no one better to speak now as our next panelist than Ioannis Tolles. You're there, excellent. Ioannis, you'll obviously your unit, I think, is looking at the EU health data space, but your particular specialism is on questions of liability and some of those challenges that we heard already around how different sort of stakeholder groups may be impacted by the increase in healthcare AI use. So over to you, and look forward to hearing your thoughts. Over to you, Ioannis.
Thanks a lot, Simon, and thanks a lot for the invitation and for these excellent discussions we have. I will use my 7 minutes I have, I think, to introduce 2 areas of our work. One of them, as you said, on data, the so-called European health data space, and the other one, exploring challenges in the area of AI in healthcare. Of course, I have to say that this is work in progress. We are still at the brainstorming stage and developing this work, so there is nothing concrete as of yet. But I may tell you that you may see an Inception impact assessment that we have published a few weeks ago, so you can find it online. You can see some of our ideas, but also you are welcome to access a public consultation that we will publish towards the end of April, beginning of May. And you are most welcome to also fill it and send us back your feedback, as we will analyze the feedback and see what your ideas are as to what we are thinking on these issues. So if I start the first part of my talk on data and the European health data space, how we divide the questions on data, we divide them into 2 main sub areas. One of them is what we refer to as data for primary use, and the other one, what we refer to as data for secondary use. For primary use, we usually refer to data that the patient is using for his or her own personal health care. For example, I go to a hospital and I want to have access to my health records, to my medical images, and I want to transfer them to another healthcare sector, or I want to transfer them to another member state. So that's the idea there, and we see problems now concerning that one, the lack of patients having access to their health records and to their data, but also questions of interoperability between healthcare providers in transferring data from one hospital, for example, to another. So one part of the work is to ensure that we have the structures, safe structures, GDPR compliant structures, that interoperable structures that would be carrying out that work. The second part concerns the secondary use. Secondary use would be, for example, a researcher who wants to access data of what the previous speakers have said, that I want to train an algorithm and I want data. Where do I find them? Now they're scattered or not even accessible or usable. So the idea here is to, of course, as I said, we're still brainstorming stages, but one of the ideas, it could be to create little satellites in Europe. You may think of them as little satellites. Each satellite could be a data permit authority. A data permit authority would be connected to different data holders, for example, hospitals, universities, whoever has data. Then the researcher would be able to go to a data permit authority and asking for inquiry. For example, I want to train an algorithm on cancer images on that specific aspect. Then these data satellites would be interoperable and communicating with each other within Europe, and you will be given the opportunity and the clarity where to find this data, how to access them. Maybe it wouldn't be possible to obtain them physically, but you would be able to virtually maybe go to virtual environments and train your algorithms there. So that's a bit the idea. And of course, this ecosystem of, if you want, or these satellites, they would be, of course, subject to GDPR rules. It would be a safe environment. It would be providing governance issues of how the system would be working. It will be interoperable, of course. If you want to be a satellite, it will be interoperable. And also, it could be also ensuring that there is the same understanding as of quality of data and having standards of data. So you know, for example, in advance that I want to access quality data A, B, C, and so on. So it could be also labeling and quality of data also incorporated within this European health data space. Now, if I move to the second area on AI in healthcare, what do we see there? Maybe I will give you just a few numbers, despite that these numbers might not be completely accurate in the sense that it depends on how you define artificial intelligence, how you define a medical device, for example, based on AI. So there might be different opinions on those issues. So that's why the numbers might not be precise. But just to give you an idea, from 2015 to 2020, there were around 220 FDA-approved medical devices based on AI and machine learning in the US, and there were around 240 CE-marked medical devices based on AI in Europe. Another interesting number is that the majority of them, around 50%, I think, were used for radiology. And another interesting number, it's around 80% of these were intended to be used by healthcare professionals. And now the interesting thing is that if you look at these medical devices, which were approved either by FDA or CE marked, you will see that primarily they are used to provide information. So here, it could also have legal implications in the healthcare, in the sense that we do not have robotic AI, completely autonomous robots, but we have information systems which are providing information. At this point, you may ask, of course, okay, they are providing information, then what is the distinct legal implications there, since we already had information systems in healthcare before AI? For example, the MRI, it provides good information to the physician, and then why do we talk of legal implications since information systems were already there? I think, and this is personal research view, you may access a paper I have actually on the New York University Law School website. I think one of the issues which might be changing there is the fact that this type of information that the AI is giving is popping into a domain that traditionally has been perceived as requiring human intelligence. It has been a domain which was traditionally reserved for humans, for a human doctor to provide the diagnosis. In other words, we had the MRI image, the little dots in the MRI, but it was the physician who was translating the little dots into diagnosis, into prognosis, into management of the patient, and into treatment, which are the four main tasks of a physician. So this translation was taking place by the physician. Now the AI pops a bit into this domain, which is not necessarily bad. it just creates, and this is my argument and my thesis, that it creates probably a different interaction and relationship with the doctor. Now, this interaction and relationship, of course, it could be beneficial in the sense that it could be providing new potentials and new inputs. But we have to see also the other side, where it could be also raising questions on ethics. It could be also raising questions on bias. It could be also raising questions on trust and confidence. And it could be also raising questions that, is this new interaction now acting towards the best interest of the patient? So if we then see this interaction now, this new interaction, of course, the next question would be, how do we regulate this interaction? Of course, regulating interactions legally is not something new. The medical devices regulation, for example, regulates some type of interaction. It ensures, for example, that you're trusting the medical devices. So what I said about trustability, bias, and so on, these regulatory frameworks already see these things. Also, what you heard in the morning, the new AI regulation, proposed regulation, could be also part of this regulatory regime to regulate these interactions. But then coming also to liability, if you see in a normative approach, liability frameworks in general, doctrinally, and in a normative approach, they could be also regulating these interactions. Of course, before you get into the solutions, I think it's also interesting to see what are the challenges within this interaction. And here, I think we may see, I may divide them into three types of challenges. One of them, we see certain technical challenges in the area of medicine, which I think they make it a bit more specific compared to other domains. Technical challenges, I refer to, for example, challenges when you're determining the task of when you're training an algorithm. It might be not a binary classification task, for example, in medicine. And to be more precise, for example, you might have question marks or disagreements as to what the task of the AI should be. Should it be, for example, to prolong life, or should it be, for example, to have a better quality of life? Also, in the labeling for supervised learning, it might be disagreements also in medicine sometimes, cancer, no cancer, nodule, no nodule, and so on. So we may also have or causal inferences, the pathogenesis of diseases. There might be also disagreements in healthcare concerning that. So we may have a bit of some challenges there that they're a bit distinct in healthcare. Then we also see some challenges in daily clinical practice. For example, an algorithm might be performing very well in the lab, but when you take it to clinical practice, depending on how that healthcare system is structured and functioning, it may have different implications and applications there. And finally, we also see some legal questions, some legal challenges. For example, what should the patient know? Because the patient might be also claiming, I didn't know that you have used an algorithm in this interaction between the doctor and the doctor and the AI. I should have known about it. Of course, here, this is not something new. This is regulated already by the so-called tort laws of informed consent. So these questions, or for example, what is the standard of care as of malpractice? Should now the standard of care change? How should it change? So these are the questions without getting to the answers, but I'm raising the questions rather than giving the answers or the issues that they might need to be addressed. And at the end of the day, and this is my concluding remark, is that we see, and I think this is what I was trying to show, this new ecosystem of correlations between the medical devices regulation, between the new proposed AI regulation, horizontal regulation, between, for example, informed consent, between medical malpractice, between the new interactions of the doctor. There is nothing correct or wrong or bad or fearful, but the question is that you make all this ecosystem and all these elements to work together, that they will be at the end of the day acting towards the best interest of the patient and also providing best interest for healthcare. Thanks, Simon.
Thank you so much, Janos. That was a really authoritative overview and a lot of content. I love the point there clearly around as well the data permit authority or the data satellite notion. I'd love to know what either fellow panelists or audience participants think of that notion. So that's excellent. I'm conscious of time, so I will move to our last panelist, if I may, and then we'll come back in the discussion very shortly. We've had a few questions coming in for you, so looking forward to providing those in the panel discussion shortly to follow. So thank you very much, Janos. Our fourth speaker is Roberto Zicari. So introduced Roberto already from the Big Data Lab in Frankfurt at the Goethe University. So you've actually looked at and more recently developed a particular practical tool to assess trustworthiness in practice, this Z inspection. So I think that will link hopefully nicely to some of the theoretical challenges we've heard already. So over to you, Roberto, for your thoughts.
Thank you, Simon, for the nice introduction. And thank you, Janos, for the excellent introduction to what we're doing. We've been working for 2.5 years now on developing a process for assessing trustworthy AI in practice. So there's been a lot of work from the high-level experts that define trustworthy AI framework with the checklist and a number of requirements. But what does it mean to really look at if you have a case of an AI and you want to know if it's beneficial? So how do we know when an AI system is beneficial or not? And we've been really working as practitioners in this space. And I'd like to share with you in this couple of minutes a use case that we've been working recently, and we completed the assessment. We've been working with the so-called Emergency Medical Dispatch Center of the city of Copenhagen. They're actually handling the health-related emergency call 112. So you call medical doctors. And in fact, what happened in this city is that when you call 112, 25% of cases of so-called out of the hospital cardiac arrest. So when the heart starts beating and somebody like a bystander is calling in panic, they're not recognized by the paramedics. And they lose the opportunity to provide to the caller instruction for some kind of resuscitation, because if you don't do it in 5 minutes, there might be a brain damage. So what they did is we've been working with them. They have worked together with a startup, and they implemented a machine learning framework that was supposed to help the medical dispatcher to recognize, by listening to the call, cardiac arrest and informing the dispatcher faster. So they did actually, so the idea was good. So assist medical dispatchers when they're on the phone as an alert system. Interesting, because Janis actually said, well, in lab, it seems to be working very well. That's actually the case. They did a retrospective study. They analyzed 100,000 emergency audio files in 2014. And the machine learning compared to the medical dispatcher was significantly more accurate and faster. They even did a randomized clinical trial, which is very quite amazing. You know, they took 5,242 emergency call and split 2 groups, one with people only and the other one people and the machine learning. And the result was there was no improvement. Although the system, and this actually been published in January this year, the system was put in production in fall 2020. Now, you have an AI system that in the lab performed very well, in practice does not perform well, and the key question is why dispatchers don't seem to trust the AI system? Is the AI system helping or harming people? So, and this is really how we come to play. No, we've been doing this process, which is a kind of either due diligence if a system, like in this case, is already being deployed. And of course, it's a self-assessment. Again, in this particular case, there's no law, maybe as we was discussing before, it will come, but this is a self-assessment conducted by a team of independent experts, that is us, which have no, like a pro bono initiative, together with the stakeholders, so with the doctors. And the main motivation is to verify if we could really have an AI system that is helping, but at the same time looking at all the possible pitfalls, and are in 3 categories. There are ethical and societal issues. There are technical issues. There are legal issues. At the end of the day, and I think I'm taking the role in this panel of the representative patient, what it really matters is if the AI is helping saving life. And this is really the key. So with all the claims, with all the promises, it's important to verify claims. It's important to have evidence. This could be done either when the system is being already deployed, like in this case, but we've also been working with this initiative that we call Z Inspection at design time. So we're working together with engineers at the German Research Center for Artificial Intelligence, designing a system for detecting skin cancer at early design phase. So you can see that as two possible ways, early design phase, where you raise issues, bringing stakeholders that are multidisciplinary. That's the key of our approach. You bring in philosopher, you bring in policymaker, you bring in domain expert, you bring in engineers. Very unusual in engineering. Or after the deployment, you want to see what happened. And you need to also consider the system change over time. So my favorite idea is you cannot certify an AI like a fridge that is consuming energy and then nobody comes in your house. This is an ongoing process. It has to be monitored over time. They do it, for example, in other areas, like when you bring your car for inspection. Somebody decided that every 2 years you have to bring your car for inspection. And there's a reason for that. And I think we're going to see a lot of interesting development. And our process, which is an open initiative, so everybody who's interested in what we do could contact me. And we're really working, showing best practices, basically taking the work of the Trustworthy AI in principle and apply to best practices. We have now published the process, so it's under Common Creative, so it's open access, and we're working on several use cases in healthcare. We'll be very happy to be in contact with whoever think is interesting to share contact with us. And with that, I'm already finished. Thank you.
Thank you. Thank you so much, Roberto. Again, a really good use of that practical study from Copenhagen, and interesting thoughts there, particularly bringing in the patient perspective. And ultimately, the key question of any application of AI in healthcare is, what does it mean for the patient, and sort of how can the patient derive benefit from that? Thank you so much. So great to welcome back the rest of our distinguished panel. And I think thank you for all of your different thoughts. You've been listening to each other as well, of course, and will, I'm sure, comment on what you've heard. We've also had a couple of questions coming in from the audience, but I'd involve others to use the chat function there. Maybe if I can sort of start things off just with one sort of question, which is around what the EU can do. So clearly we've got the artificial intelligence actual proposals coming through, but we've talked today, aside from that sort of question, we've talked today about a number of different complex challenges. So if there was a single thing that kind of sort of united European efforts could focus on, what, in the panel's perspective, what could that be? I'd love to sort of hear some thoughts there. And whoever would be keen to perhaps look at that. Maybe Lubna, you obviously were involved at one point in time. If there was one single thing, what could that be?
So one single thing is getting our data from the different member states, the healthcare data, together and linked and in one place, so we can build AI and test it on top of that. If we don't, we will go as innovators and researchers, we're going to do that on smaller scale, and it's going to be silos. So we need to create a sandbox environment across a number of member states where we can test those algorithms and measure their performance from the baseline, which is today's practice, the standard care environment, and how much value added in terms of impacts for patients as outcomes, as well as in terms of costs. Without that, we will be doing, as we saw with COVID, every country will do different things than the other one, and the scale element of AI, and that it's adding value and leveraging all the data to solve the healthcare problem will stay local. And that's, I think, the main thing.
Thank you, Lubna. Any other thoughts on that? And I'm thinking as well of, Yannis, you talked about the data satellites as a specific concrete idea. I wonder if anyone had any thoughts on that. Or Yannis, if you wish to address the broader question.
Yes, of course, what Lubna said, that's the idea of the European health data space. That would be the idea of creating, as I said, a researcher would be able to request data in one of these data permit authorities. Then this data permit authority, the idea, it's still brainstorming ideas, as I said, we're at the beginning. That's why it will be good to also collaborate, to get your feedback in our consultations that they will start being published, and then targeted consultations and so on. But the idea is that a researcher, for example, would be able to go to one of these data permit authorities, one of these little satellites, and asking for the type of data that they would like. Then there will be interoperability and communication throughout Europe of different satellites. They will be giving your question to different little satellites. Each satellite will be also connected to different data holders within that member state. And then they will be indicating to the researcher where this data that you're requesting, for example, could be found. It could be, for example, a bit of in Denmark, a bit in Greece, a bit in Italy, and so on. Now, exactly how, and also you would know that this system is interoperable, is safe, is secure, is GDPR compliant. There is a governance issue governing this thing. So it will create also this trustability, because I think that's very important. It will also have the right infrastructures for this thing to work. So we're working on all these domains. Yeah, that's, and as I said, the final thing is that you may not, but that I think that's no problem. The data might not as such be moving always for data protection and so on, but you may be moving to virtual environments where you would be able to train your algorithms in those virtual environments, and then live from that data, from that virtual place. Yeah, that's a bit I think what it could be an idea and what we are thinking about.
Excellent. Great to have those sort of thoughts. Laura, did you have a view from a user perspective then?
I have a view from an academic's perspective, if I may. So currently there's no incentive to share your data in the academic world. So we know that obtaining the gold standard diagnosis that you need to train an algorithm, or to collect the longitudinal follow-up data to be able to develop a prognostic algorithm, or to label your data to make an imaging-based, for example, deep learning or other AI, that's very costly. And what we see in academic research is that people don't share their data because there's no incentive. The way research is rewarded right now, what we are rewarded for is for publishing our results. The EU could take a role in not only fostering research papers as output, but also making publicly available good quality data, accessible data, and give incentives to that, fund researchers to collect that data. And I think from an open data point of view, that would be very helpful.
So actually providing the funding for the research and the right incentives being in place.
Mm-hmm.
Yeah, excellent. Okay, any other thoughts on that other question? Otherwise, I think we've had a few, and I'd like to come back to the question of trust, actually, and bias, because I think that came up a couple of times. But perhaps first, we've had a few questions in from the audience. So I think first, Yannis, there was a question that came in from Frédéric Corriveau from the DNV, who mentions AI and especially machine learning as a moving conformity target with a risk to assessment of safety and performance, linking to the MDR. And do you foresee a way to ensure continuous conformity monitoring of machine learning driven medical device software? It's quite a technical question, but any thoughts on that?
Yes, I think there is two issues there. Of course, yes, if it's referring also to the idea that some machine learning algorithms could be also continual learning algorithms, that they could be continuously learning after they are deployed in healthcare. Of course, to be fair or to be correct, we don't see this thing in healthcare, I would say. So it sounds interesting, and of course there is research about it, but let's not also create the fearing, scary idea that now there are algorithms in healthcare that are open and they are deployed in healthcare and they are self-learning and maybe changing their character completely from what the manufacturer intended them to be, and they're changing to something else. Of course, they could be collecting data, but then there will be another retraining backwards. But that one, I think it's, yeah. So in that sense, I think this kind of idea of continual learning in healthcare, I think it's maybe not at the moment there. Now, as to the MDR, yes, of course, the MDR, as you know, it was recently adopted in 2017. It's coming into application in 1-2 months, which it becomes very comprehensive, updated, takes into account all the software that could be also predictive software. So it will take into account all these issues and monitoring it after its deployment. But of course, what you heard in the morning, the new horizontal AI proposal would come also to complement or to stand next to the MDR. So the idea there, it will be that an AI medical device, if I were to put it like this, it will be now more secure in the sense that it will be also complying with the MDR obligations. And in addition, those aspects of AI that could be creating some worries and some concerns would be handled by the new AI regulation. So the two would be ensuring that the system is secure and trustworthy and so on. That's the idea. So in other words, if you to get the CE marking, maybe you would need to fulfill a number of requirements, among them these issues. And the other, of course, issue is what Roberto said, the post-deployment issue, but not as of continual learning, but when this thing that he also built on what I also said very correctly, which is the post-deployment. We see some challenges in the post-deployment stage because, for example, different healthcare settings might have even different protocols, for example, in the hospital of how they do their work, something that it could not be even perceived at the time when the machine learning algorithm was prepared or was developed and trained. And we see, and to give you a concrete example, there was a study, for example, in the US, where they deployed the same algorithm in one teaching hospital and in a non-teaching hospital. And they have seen that the same algorithm in the non-teaching hospital, I think, the death rates increased, and in the teaching hospital, they decreased. Now, why in the teaching hospital they increased the death rates after they deployed the AI there, and in the teaching hospital they decreased? That's something with what also Roberto raised. You have to also see how maybe it was used, why it was used in that way, what were the peculiarities of that healthcare setting, maybe what protocols they have, how they trust, how they work, the whole culture maybe in that hospital. So there is also this thing. And if I raise another little point, which I think also shows these peculiarities, is, for example, we usually very often say we want interpretability of AI in healthcare. And it's something that I do believe actually, and I did support actually my research in this paper I have written. I do support it very much, that interpretability would be necessary and it will be needed. However, we have to also make it clear that in recent research, they also found that even AI systems which were interpretable sometimes were over-trusted by doctors, even when the AI system was giving the wrong explanation. So you see that there is this, it created also this bias by the physician towards explanation given by the AI, even when the AI was giving the wrong explanation, which I think is interesting,
Mm-hmm.
which shows that there is kind of some new elements there. And this is what we're trying to explore and find, and we're finding more and more of these elements, which I think they made it more interesting and more challenging at the same time. Thank you.
I'd love to get Roberto or Laura, anyone's comments there, but the specificities of the healthcare setting, but kind of bias in trusting the machine. Laura, that seems to link into some of what you were saying in your presentation.
Thank you. They are muting me, so then I'm happy to give some example. I think Janos has actually mentioned something extremely important. There is even a bias at the level of interaction between patient, medical doctors, and the machine, and this overtrust or alert fatigue or all these kind of things. They're actually new things. And actually, my experience is I also mentioned about this question about the new directive on law. In our case, in the 112 emergency call, surprisingly, because of the gap in the law, the software that is supposed to help medical dispatch is not registered as a medical device. It's not. Well, it should have been, and it will have to be if the new law comes into place. And also, we've seen we did some assessment on products that are level 1 non-invasive, low risk. They don't have to do any clinical trial. So the law will definitely make sure that some of the normative will be in place. But then I want to make a comment on what Lopna said about screening. Because I was, I'm not a medical doctor myself, so I brought in our team medical doctors to give us evidence. And in the design of a product for detecting skin cancer, we end up discovering there is not a clear evidence between those people that think the screening is good and those people in medical evidence that says screening is bad, overdiagnosis. So all of a sudden, what is happening that an engineer that is actually designing an AI tool, and he has not really all this discussion because normally you don't have all these stakeholders, is embedded in the tool already the definition of what is healthy and what is not. And nobody knows. And if you are a patient, wow, you might want to know what is inside the ethics of this tool. And we need to verify claims. We need to verify claims and helping engineers to be aware. Almost no engineer has studied in school ethics. So
a key point of bringing the art and the science, the artificial divide, but I think the importance of ethical considerations and reflection in the development and the software development of AI. Laure, I think you are wanting to comment. No, not on that. Excellent. So one question that's also come in here is just thinking a little bit, building on that sort of theme of the ethical implications. So a question has come in here looking at sort of to Lubna, in fact, around the focus on collecting international data to facilitate disease prevention. But there is an ethical question perhaps linked to that. Is it an opt-out or an opt-in sort of system? And how would you feel in a family, for example, with a history of inheritable disease, if your status was being shared without restriction? So any thoughts on the sort of ethical aspects of data sharing?
I think there is a trade-off between what is ethical and unethical. What is ethical in case our data is shared, what's the potential harm that can happen? But there is also the ethical questions if there is data about specific diseases and then patients have the option to opt out, that we will not learn as a public healthcare system from those to serve other patients. So there is the question dilemma, is it ethical when we have that data but it's not used, we have the technology but it's not used, versus the ethical dilemma when someone has the right to choose or not. So it is, for example, we saw with the COVID around the genome sequencing, for example, in the UK, it's happening here in Cambridge at large scale. Because of that, we could detect the Kent variant early on. So we see the benefits of that. Is that up to one person to decide? or is it our right as population to be able to leverage that data? I think in Europe, we are very good in setting the right principles around data collection and having the GDPR in place and having all the security mechanisms in place. Then the question, do we want to use it? I'm a liberal. I think, for example, everyone as a donor scheme. So if you want to receive a kidney at some stage, you also need to be on the donor list. That's my personal opinion. So if you apply the same mechanism here, if you don't want to share your data, then other patients' data won't be leveraged to help you. So of course, this is up to member states to decide on what approach, if there are what ideology they have, what is the current state of democracy there, and what people think about it. But I think it is not only the right of one person. Once we discover something, we need to be able to leverage that knowledge, and we'll be able to serve many people of that. And we saw that data is not. It's more than just data. We have our own history in the past in Europe. That's why we have strong foundation for data privacy. But it changed from being used against people to being used to drive our economies. We saw the example of Israel. By leveraging their data, the healthcare data, they got early access to the Pfizer vaccine. So it is more than just data. It is the new currency for our economies. It is the new fuel for our healthcare system. So yeah, what is the best approach? I believe the more data we collect, so we can tackle diseases, and is the right way to do it.
Very helpful. Any other thoughts on that, Michael? You trying to speak there?
Perhaps just a reflection on this, and this is also my personal opinion. We also have in Europe a societal commitment to keeping people safe. I mean, and keeping people healthy. There's a social responsibility that we assume as a community to keep people safe. We have social safety nets, and so that also needs to be balanced or enter into the equation. Does one, as the individual, perhaps have a responsibility of sharing their data if we as a society want to keep that person safe? Does that person, so we need to find an appropriate balance between societal benefits and individual individual right to privacy. But again, this is my personal reflection here that I think we all want to probably keep in mind.
Very helpful. Thank you, Michael. Okay, I'm conscious of time. We have said we've been told we can go over slightly, but I'm mindful as well of respecting people's agendas. So, but I think really helpful to kind of hear a little bit more about the trust and ethical sort of components there. So thank you, Lubna and Michael, for that as well. Did anyone from the panel have any particular sort of points that they wanted to finalize with, to finish off with, or any things they wanted to say about other presenters they haven't had an opportunity to say? No. Okay. So in that case, I think just again, mindful of time, thank you so much for what was a really sort of inspirational, I found very informative set of presentations there from you all. I think from that sort of last session, and I think we'll hand over shortly to James to round off, but there are a few take homes from me as a non-expert listening in. The opportunity from health in terms of healthcare AI, in terms of better treatment of disease, the fact that it's not to do with replacing birds. I think that comment struck home, but it's augmenting health stakeholder decision making. The key link to prevention, so leveraging healthcare AI with a means to an end, so with a means to of moving towards a prevention service. And then what are the incentives that need to be in place for that to happen? Getting the data right is central. So the numbers are only as good as the process that produces them, to Laura's point. And then finding that critical key balance between protection and access, perhaps the health data space as outlined by Eunice earlier. And finally, I think Roberto, and we're getting into some very interesting thoughts there on the changing sort of psychological and ethical implications of the use of AI by practitioners, which will be the field, I'm sure, for much more research in the years to come. So thank you all for great panel discussions there and your input and your time. And now over to James for closing remarks.
Thank you. Yeah, thanks everybody for your participation there, everybody on that panel. And yes, thank you, Simon, very much for that very clear and concise wrap up. So that concludes this year's AI Forum Europe's AI 2021 conference. I hope you found today's gathering interesting, and thank you again very much for being with us. A reminder that all the sessions will be provided to you as replays very shortly, and this includes all the content from the AI Research Hub element on the platform as well. So you'll be getting all of that on email in due course, and it'll also be available on the event website. So thanks once again also to our sponsors, the BSA, the Software Alliance, Microsoft, and SAP, valued partners once again this year. So thank you very much to them. A big thank you to my Forum Europe colleagues, and in particular David Kirby, for his and their work on bringing this together. It's been a pleasure to host you, and the chat was really active. You can see there's a lot of engagement across the day, so thank you to everybody for that. If you've got any questions on this event or any of our other activities, please do reach out to us, and we look forward to seeing you again very soon. So wishing you a very pleasant rest of the day. Thank you very much.